Welcome to Living Well with MS. This show comes to you from Overcoming MS, the world's leading multiple sclerosis healthy lifestyle charity, which helps people live a full and healthy life through the Overcoming MS program. We interview a range of experts and people with multiple sclerosis. Please remember, all opinions expressed are their own. Living Well with MS is listener supported. If you'd like to support us and help keep our show advertiser-free, donate online at overcomingms.org/donate. And now, let's meet our guest.
Welcome to the latest edition of the Living Well with MS podcast, where I'm very glad to welcome back Dr. Aaron Boster.
Howdy.
And Dr. Boster is an absolute expert in multiple sclerosis and is the founder and owner of the Boster Center in Ohio, US, and is here to give us some excellent expert advice on DMTs, from the latest to the oldest somewhat. So we're going to cover the whole gamut of DMTs. So welcome again, Aaron. It's been some time since I last spoke to you, but I hope you're well.
It's nice to be back. Thank you for having me.
So if we get straight into it, because we're going to cover loads of DMTs here. So to start off with, can you give us a broad overview of medication choices for people with MS and also how they've improved over the last 20, 30 years?
Absolutely. So I would start by saying when I think about helping someone with multiple sclerosis using medicines, I divide my thoughts into three categories. When someone has an MS attack, we're giving steroids or things similar to steroids to hasten their recovery. And so that's one category, which hopefully, if we do things right, we don't have to do very often. A second category of medicines is improving quality of life through treating symptoms. So as an example, if you have a bladder urgency with risk of accidents, we give you a pill for that ill. Today, we're focusing on the third category of medicines, which are medicines created to change the natural history of the disease, to literally modify the course of the disease in our favor. To be a little bit more granular, when we look at the medicines that have come out over the past couple decades, we're really trying to decrease attack rate, decrease new spots on the MRI, and to slow disability progression. And those are really goals of modern MS therapies. It's not to make you feel better in the now, it's to preserve the neurologic reserve so that 30 years from now, you're still active in the game.
Okay, and firstly, I know the answer to the next question I'm going to ask. And the reason I know the answer is because you have an excellent podcast. So just to say to anyone, very well worth not podcast, YouTube channel. I mean, this podcast. Go on to your Go on to YouTube.
I'll mail you your $20 as agreed upon earlier.
Yeah. Nice. But yes, definitely subscribe to Dr. Boster's YouTube channel. So when should patients start a DMT is the question.
So the earlier we start a disease-modifying therapy, the better the human does long-term. And this is not an opinion. This is very strong science supporting this idea. When we think about some of the earliest drugs, I'll use the medication Rebif as an example. When we first tested Rebif, we randomized people in a trial to either Rebif or a dummy drug. And we followed them out for 2 years, looking at the frequency of their attacks and their disability they accrued on exam. And at the end of 2 years, the people on Rebif stayed on Rebif, and the people that were on placebo then started Rebif. So they started at a 2-year delay. Mm-hmm. What we learned was really striking. The people that were on placebo for 2 years, just 2 years, and then got on medicine, they had accrued disability they never regained. And so there was a break between the two groups, and the delayed onset group never caught back up. If we take that a step further, looking at more modern efficacious drugs, because we now have drugs on the market that are arguably better than the earlier drugs, we've done trials where we start someone on what we would consider a high efficacy drug in one group in a clinical trial, and then another group in the trial got low efficacy drugs for 2 years. Then at the end of 2 years, all the people on the low efficacy escalated to the higher efficacy. So a very similar model. And we learned the exact same thing. 2 years on a lower efficacy drug resulted in a disability accumulation, and they never caught back up. So the totality of evidence is very clear that the earlier we start, the better chances we're going to have to control the disease.
And what should people think about if they're consider? Because there's a huge amount of choice for drugs now. So what are the factors that people should consider when they're choosing which drug to go on?
That's a very appropriate but big question to tackle. So I want to try to unpack it a little bit. The very first thing that I, as an MS neurologist, think about is efficacy. And that doesn't mean that we go on the most efficacious drug, but I want to stack the deck in your favor. So the first thing I'm going to think about is how effective is that drug? And the phrase that I've cultivated is, I want you on the most effective drug that you're comfortable taking. So that doesn't mean that it's going to be the most effective one that you're eligible for, because it's real big of me to tell you, hey, that's a good one, but I'm not the one taking the medicine. You have to take it. So another way of saying that is, it's really a mix of efficacy, tolerability, safety, and dare I say, cost, because these medicines in different healthcare systems in different countries can be very, very expensive.
And just as an outside, would you say that the more efficacious drug has the more side effects then, typically?
I think that if we speak in gross generalities, that might be true. I think it's becoming less and less true. So I don't think it's a foregone conclusion. I'll give you an example. The medication alemtuzumab, Lemtrada, has a tremendous amount of side effect risk up front. And then a couple of years in, there's no risk. And so depending on where you slice that pie, the risk profile changes. So it's not as straightforward as high efficacy means high risk. Although I think in gross generalities, we can kind of think like that.
Okay, so we're going to get through a whole load of disease modifying therapy. So let's get into that. So talking about so when I say DMT, it's disease modifying therapy or drugs that we're using to treat MS. So we're going to go through each one on the market. So for each of these, could you tell us about how effective it is, how efficacious it is, how it works, who it works for, how it's administered, and any benefits and risks that you think people should know about when considering it? So we're going to go through in alphabetical order. Go on, sorry.
Sounds good. Now, the one thing I want to say, just as a caveat, is I am pretty biased. And so I'll try to be as level-headed as I can, but my bias may come out in some of my answers.
But you don't work for a drug company or anything? No.
I'm a practicing MS neurologist. I'm just sharing with you that, I have some.
You're biased in your beliefs rather than biased commercially.
Correct. That's what I meant. Yep.
Yeah. So we're going to start with one that actually I've had, but that's just by chance because we're going alphabetically, and you've mentioned it just now, which is alemtuzumab or Lemtrada is its trade name. So how you've mentioned it is, well, you've introduced it, but
so
how efficacious?
So Lemtrada is a monoclonal antibody. So it's a biologic agent made in a laboratory, and it's an antibody that has a very specific binding when you infuse it in the vein. It identifies adult B and T cells and murders them. And subsequently, the cells that grow back more well-behaved. Lemtrada is a discontinuous therapy. You take an infusion in the vein for 5 consecutive days, then you wait a full year, then you do an infusion in the vein for 3 days, and then you've been induced, then you've been treated. And then we're looking for a durable effect in the absence of retreatment. We don't retreat patients typically unless, God forbid, they have breakthrough disease. My biased opinion is that alemtuzumab Lemtrada is one of the most effective drugs currently available on the market. I think that it's outstanding at relapse rate reduction. It's outstanding at decreasing new MRI activity. I think one of its shining elements is its ability to slow brain volume loss and to slow disability progression. I would also submit that it has some of the best data for confirmed disability improvement, where some people get better. I also say that Lemtrada, hands down, is probably the most complex drug with the broadest risk profile. And so I'll divide the risks into 4. When you take alemtuzumab Lemtrada, there's a high risk of infusion reactions physically during the infusion. This is not to be taken lightly. There's actually been 13 cases of strokes during infusion, nothing to laugh at. More commonly, we're dealing with a red rash, itchy throat, tachycardia, heart rate changing, wicked headache, joint pain, things like that. But the infusion reactions require a careful hand. We use a lot of medications to kind of ease things out. The infusion reactions don't last much longer than the duration of the infusion, fortunately. The second category of risk with Limtrada, which is somewhat unique to Limtrada, is it can cause autoimmunity. So we're treating an autoimmune condition, MS, but when you take Limtrada, there's a 41% chance that you'll develop an autoimmune thyroid problem. Now, this is oftentimes very easily treatable, but that doesn't make it okay. There's a 2% risk of having an autoimmune condition with the platelets, with the way that you clot your blood. And there's a Scrabble word, it's immune thrombocytopenia, which is a doctor way of saying the platelets don't clot. And there's a very low risk, less than 1%, of autoimmune kidney or liver disease. So that's a lot of things to consider. The third category of risk with Limtrada is infection, because you're knocking down the cells and they take 6 to 9 months to come back. So during that period of time, there is an increased risk of infection. Two specific infections that we pay very close attention to. One is the varicella, so shingles. And we oftentimes, at least in the United States, put people on prophylaxis with medicines like acyclovir or valcyclovir for sometimes years to protect them from getting shingles outbreaks. And we also worry about listeria, which is food poisoning. And we kind of use what I jokingly call a pregnancy diet for a period of time after the Limtrada. Now, the fourth category risk is the lowest risk, but the scariest word, and that's cancer. 0.3% risk of thyroid cancer, 0.3% risk of melanoma, skin cancer, 0.2% risk of blood cancer, lymphoma. So as you can see, we're dealing with a very, very high efficacy drug taken in a very weird, discontinuous manner with a very significant upfront risk profile. Now, to take the medication, we then check labs monthly for 4 years after the last dose so that we can monitor for all those risks. When you make it out past the total of the 5 years, you're no longer needing to check those things because that risk tapers off. And that's maybe Limtrada in a nutshell.
Okay, so we'll carry on because we'll get to him quickly. So next one, cladribine or Mavenclad. That's the trade name.
So cladribine or Mavenclad is a micro-induction therapy. These are pills that you take in a very weird way. You take a pill Monday, Tuesday, Wednesday, Thursday, Friday, so 5 consecutive days on the first month, and then you're done for the month. So I always joke it's like a reverse birth control pill. And then on the second month, you do that again, Monday, Tuesday, Wednesday, Thursday, Friday. And then you're done for the year. So you've taken 10 pills that first year. And then on the anniversary, you repeat that process once, 5 pills the first month, 5 pills the second month, and then you don't take any more medicine. You're followed and observed without being retreated unless you have new disease activity. So similar to alemtuzumab, Limtrada, cladribine is a discontinuous therapy. It's a microinduction. What is it doing immunologically? It's really focusing mostly on the B cells. It has a small impact on the T cells, and it knocks the B cells down, nowhere near as far as with Limtrada. And when they come back more well-behaved. So just to highlight one aspect, memory B cells, which in the setting of MS, unfortunately, remember your brain is a bad guy, a foreign invader. When you take cladribine, you knock your memory B cells down substantially, and they only come back about 13%. So you're really removing somewhat of the immunologic memory. Now, the data for long-term use of Mavenclad is complicated because the trials were stopped and started, and so we don't have complete data sets. But there are at least some patients that we follow that go out 10 years and never get retreated, which is pretty darn exciting. Now, from an efficacy standpoint, I think the trial for Mavenclad demonstrated a really robust reduction in relapse rate, very impressive. The disability progression in the trial was but I've been very enamored with what we see with disability progression looking long-term. I actually think the medicine does a heck of a job of controlling disease progression over time. And it also does a really good job cleaning up the MRI. So I think this is a drug that deserves to be in the high efficacy category. I also feel that the risk profile is a little bit more easily tolerated, maybe compared to Limtrada. So when we need to be thinking about liver and kidney when we take this medicine, we need to make sure that we've been immunized so that we don't have opportunistic infections. Again, we have to think about varicella, things like that. There's a very small risk of cancer. I would submit maybe about a 1% increase overall compared to the general population. There's no pattern to the cancer. And at least here in the United States, the screening is age-appropriate cancer screening. So the FDA here did not recommend advanced screening. You know, when you're of the age of the mammogram, you get the mammogram. When you're of the age of colonoscopy, you get the colonoscopy, et cetera. And the infection risk with cladribine is actually a lot less than most people would think. And that has to do with the way the drug is operating, because it doesn't knock your cells to nothing. So you always have immune cells present. You can still fight most infections. So that's cladribine in a nutshell.
And I think, are those both relapse remitting only? Or
Thank you. So I apologize, I didn't do it. So Limtrada is approved for relapsing forms of MS. And so is cladribine is approved for relapsing forms of MS. As we go through these medicines, there's only one medicine that is approved for progressive disease state, at least here in the United States. So cladribine is for relapsing forms of MS. We may see it used in clinically isolated syndrome, although it's not licensed in the United States for that. It is the rest of the world. And also for other relapsing forms of disease. Absolutely.
Okay, and the next one, it's not actually, sorry, I thought my list was fully alphabetical, but it's not. But fingolimod is the next I've got on my list, or galenia.
So fingolimod, the brand name here in the United States is galenia. Fingolimod is another unusual drug. It's a pill that you take once a day. And what it does is fascinating. It causes the white blood cells to become trapped in the lymph nodes. So your white blood cells float around the bloodstream, but they periodically leave the bloodstream, they go in the lymph node, and then they come back out. And there's a lot of complicated receptor biology which is required to get the cell out of the lymph node. When you take galenia, it causes the white blood cells to become trapped in the lymph nodes in the spleen. So you take them out of the blood circulation. If those white blood cells aren't in the blood, well, they can't cross the blood-brain barrier into the central compartment, into the brain. And so by virtue of doing that, you reduce the inflammatory cell exposure, and that has a very nice impact in decreasing relapse rate. I think galenia is quite good at reducing relapse rate. It's just okay at disability progression. I'm not terribly impressed with the data for slowing down disability progression, if I'm honest. I think galenia does a very good job of cleaning up new spots on the MRI, and galenia is pretty good at slowing brain volume loss, which is a perk. Galenia is a medicine which can impact the heart just the first day you take it. And so there's something called a potential first dose effect, where when you take it the very first day, you might have a low heart rate. And so in order to mitigate that risk, we have people take the medicine under like 6 hours of observation. They'll literally come into a clinic or a hospital, and we do some EKGs. After the first day, that's no longer a risk. There is an increased risk of infection, because this is a functional immunosuppressant, if you will, and a very slight increased risk of skin cancer. Overall, these are very well-tolerated medicines, these galenia and the family of medicines, the S1P1 receptors.
And the next one up is one that I've not heard of before, actually, which is mitoxantrone or novantrone.
Mitoxantrone, or novantrone is a trade name, has really fallen out of favor internationally. It is a potent chemotherapeutic agent, like something that we would give to someone who has a cancer. And it's fallen out of favor because of the risk profile, but it is a very effective medicine. When I was coming up through the ranks, I'm going to date myself, but quite some time ago, we used mitoxantrone, and it's extremely effective for controlling aggressive disease. FDA approved for relapsing MS, including secondary progressive MS. Mitoxantrone is a blue liquid. So a lot of times people say, oh, I remember the blue liquid. And it's infused in the vein. It's typically given in a pulsed fashion, either monthly or every 3 months, and for a set period of time. And it knocks down the cells rather substantially and then lets them come back. Now, when you use mitoxantrone, back in the day, we would put someone on mitoxantrone, then we would often put them on a standard disease-modifying therapy afterwards as a maintenance of sorts. And the reason we don't use it anymore is twofold. One, there's a risk of cancer, which is not small with the medication. And second, there's a risk of cardiomyopathy, problems with the heart, which is dose dependent. And so for both of those reasons, we don't see it used very much anymore, but it is a very effective high efficacy medicine.
Okay, and to cover a few of the MABs, then we've done our amtuzumab, but next one up, natalizumab or tysabri.
Yep. So natalizumab was arguably one of the first FDA-approved high-efficacy drugs, and it came out in the United States in 2004. I remark as we make this video 20 years later, it remains one of the most effective drugs still on the market. It's a very high-efficacy medicine. This is a monoclonal antibody. So again, it's an antibody created in a laboratory, which is infused in the vein. It's about an hour-long infusion done on typically every 4 weeks, sometimes every 6 weeks. And the way it works is fascinating. It tightens up the blood-brain barrier. And I joke, it turns the blood-brain barrier into the Great Wall of China. So it creates such an impermeable barrier that the autoreactive cells can't cross into the brain. The blood-brain barrier is impenetrable. And so by virtue of that, you keep all of those naughty autoreactive cells outside the brain and it can't attack. And we found natalizumab, tysabri, to be very, very effective at decreasing attacks and new lesions on the MRI. It's also good at slowing disability progression quite a bit. The only chink in the armor of tysabri, dare I say, is brain volume. I don't think it's as potent at slowing brain volume loss as maybe some of the other drugs. There's also one substantial risk, which bluntly I think we blow out of proportion, if I'm honest, and that's a risk of a rare but potentially fatal brain infection called PML, or progressive multifocal leukoencephalopathy. Now, to talk about it very briefly, there's a virus called the JC virus. And if you look at humans over the age of 30, about half of us have been exposed, and none of us care because it's a very not good virus. It can't really hurt us too much unless we massively suppress the immune response. Tysabri does this because there's no white blood cells in the brain. And if that virus gets into the brain, it can cause a very serious infection. Fortunately, we can test people's blood to see if they've been exposed to the JC virus, and that helps guide our treatment. I don't want listeners to think that if you're JC virus positive, you're not allowed to have tysabri. You are. We just have to look at the statistical risk, which can be as low as 0.001%. And depending on a bunch of variables, could go up to 1%. And so obviously there's a very robust risk-benefit discussion to have with the individual. Tysabri is quite an effective medicine. I'll also share with you that tysabri has a weird energizing phenomenon that not all but some patients experience, where they'll call it their go juice, and they really feel almost euphoric and energized when they receive the infusion.
And that's a positive thing.
Oh, it's a great thing. People love it.
And the next one up, so when I say the MABs, I mean the monoclonal antibodies mostly end in MAB. So ofatumumab, which is Kesimpta.
Ofatumumab, and by the way, neither Jeff nor I made up these words.
They're actually made up, aren't they? Sort of scientifically, you can break them down into bits and say it's like...
That's exactly right. We could draw them out, but suffice it to say that ofatumumab is one of the newer high efficacy medicines to join the armamentarium, just a few years old now, and it is a B cell depleter. So it turns out that when you look at the pathology of MS, the T cell is the cell that attacks you, but the T cell is not capable of attacking you unless the B cell helps it out, gets it riled up. And so what a B cell depleter does is it kills the adult B cells so that there are no adult B cells available to piss the T cell off. Therefore, the T cell is ineffective at attacking you. So it's this really clever indirect mechanism. And it turns out to be extremely effective in its ability to slow down multiple sclerosis. Ofatumumab and the other B cell depleting monoclonal antibodies have swept the MS market, and they're the most utilized, as a class, the most utilized drugs. And I think that's a combination of their high efficacy and their overall good tolerability and safety profile. Now, ofatumumab is a self-administered injection. So it's a subcutaneous shot. It comes prepackaged in like a pen. So you don't have to mess around with needles. You just hold a pen to your skin and click a button, and it gives you the injection. And you take it at home. So you don't need to go into a clinic or an infusion environment to do that. You take a shot the first month 3 times. So you take one 2 weeks later and then 2 weeks later, and that kind of gets you loaded. Then you're taking 1 injection every month. Now, some people, not most, but some people, the first injection or 2, they kind of feel flu-like. They feel kind of punky. But after that, I've heard of no such complaints. And it's overall a very well-tolerated injection. Ofatumumab is impressive at decreasing relapse rate, very impressive. It's also very impressive at decreasing new spots on the MRI. In the clinical trial where we studied it, it's called the Asclepios trials, we pitted it against a drug, Aubagio, and it was not able to outperform Aubagio with brain volume. It did decent with disability progression. But overall, I think this is a really excellent drug. And one of the advantages of ofatumumab is you can take it at your house. So not all patients have access to infusion medicine, or they live near an infusion center. There's plenty of people that I care for in rural areas of the United States where they would have to drive 6-8 hours to get to a doctor. So having access to an injection that you can do yourself, which is also high efficacy, is pretty superb. When you take the medicine, we want to make sure that you mount a response to shingles before we get started. And, there's a couple laboratories that we need to screen for, but then we're pretty much off to the races.
And one that's very popular over here, at least, is ocrelizumab or Ocrevus.
Yep. So the first B-cell depleter that was FDA approved and EMA approved was ocrelizumab, Ocrevus. So this B-cell depleter is given in the vein. It's an IV infusion. Typically, at least in my center, we infuse it over 2.5 hours. And it's given once every 6 months, which is rather lovely. And so many patients I take care of in the ancient days of yesteryear were injecting themselves with medicines daily, or taking a pill once or twice a day, or getting an infusion once a month. So to be given the opportunity to only, quote, have MS twice a year, end quote, where you go to an infusion center twice a year is absolutely lovely. Now the medicine, when you take it, you take the first infusion is a half dose, and then 2 weeks later, a second half dose. That gets you loaded. And then it's one full infusion every 6 months. And the rules of engagement are almost identical to the other B-cell depleters. So the same things I said about ofatumumab are true for ocrelizumab. With ocrelizumab, we also have to watch carefully that the antibody levels and that the white blood cell levels don't drop too far. And so we check laboratories. And if we find that they go down, there might be an increased risk of infection. And so part of the monitoring of all B-cell depleters, but I think it's most relevant with ocrelizumab, is to mitigate the risk of infection.
And this is one of just from knowing people on some of these, they talk about just before the infusion, they can feel a bit worse.
Yeah, so the way that this drug works is it depletes the B cells, and the drug stays active in your blood for about 4.5 months. But there's oftentimes a durable effect, and we dose every 24 weeks, which is about every 6 months. Now, there are a large minority of patients in my practice who report something which has colloquially been described as the crap gap.
I was trying to avoid the term, but go on.
Yeah, I didn't look it up. So this wearing off effect is argued amongst MS neurologists as whether or not it's real. I'm of the belief it is, because I don't think thousands upon thousands of people all got on like a secret Discord server and agreed to come up with a fib. I don't think that's true. And what I observe or listen to patients share with me is that maybe 4 weeks leading into the infusion, some of their MS symptoms kind of come back, whether that be a numbness or a fatigue or a migraine headaches or what have you. And then oftentimes those things kind of dissolve when they get their next dose. It does bear mentioning that, like ofatumumab, ocrelizumab is rather highly effective. In the clinical trials, we pitted it against a standard of care drug, Rebif, and it really kind of rocked the Casbah. It doubled Rebif's efficacy on almost every time point, doubled it in relapse rate, disability, and it shut down future MRI lesions 98% better than Rebif, which was quite a remarkable. So this is another.
So that's not just 98%. That's 98% better.
Correct. 98% better than a drug which is renowned for closing the blood-brain barrier. So really raise the roof. It also bears mentioning that ocrelizumab is the only drug to date, as we make this video, which has class 1 evidence proving its efficacy in primary progressive MS. Now, here in the United States, it's FDA approved for primary progressive MS. It's the only medicine FDA approved for PPMS. And the oratorio trial where we studied that demonstrated that it could slow disability progression and brain volume loss in PPMS patients in a clinically and statistically significant fashion. And so that's a go-to drug for PPMS patients in my practice.
And next one up, ocrelizumab. Oh, sorry, no, I've done that's the one I just did. Ozanammod, or Ziposia.
So Ozanammod is I call it a galenia Me Too drug. So galenia is the first S1P1 receptor modulator. That's a mouthful. That's the class of medicine, the pill. And there are subsequently a second generation of S1P1 receptor modulators. And if I speak about Ozanammod briefly, I don't think, frankly, it brings new things to the table compared to galenia. That's my opinion. I think that when we studied Ozanammod, we were smarter. And so we looked at brain volume and we looked at cognition, and we were able to demonstrate some things that I think occur with all of the S1P1 receptors, but we were able to characterize them with Ozanammod. Also, the second generation S1P1 receptors, Ozanammod being an example, have gamed out a titration schedule when you start the pills, which avoids that first dose monitoring. So starting Ozanammod or any of the second gen S1P1 receptors is much easier on the human being. They don't have to take a day off work to be monitored and have EKGs, etc. I remain disappointed in the progression data for the second generation S1P1 receptors. So whereas I think Ozanammod does a good job in controlling new MRI lesions and relapse rates, it leaves a little bit to be desired as it relates to its ability to slow down progression of disability. That's my opinion.
Mm-hmm. And next up, rituximab, which is various names, Rituxan, Mabthera, Truxima.
Yep. So rituximab is probably the oldest monoclonal antibody that we'll be discussing today. It is a B-cell depleter, so it goes in the same group as the ofatumumab, Kesimpta, and the ocrelizumab, Ocrevus drug. It's not FDA approved in the United States. It does have evidence for efficacy in relapse rate. It's not class 1 evidence, but there are trials that support its use. And I think it's widely accepted as being a high efficacy MS drug. I've even seen here in the United States, some insurance carriers request they prefer it, probably because it's less expensive than the other ones. And they want us to use that for treating patients. But it's a very nice drug. I have a long history of using it before the other B-cell depleters became commercially available.
Could it be that in parts of the world where you're in the US, I'm in the UK, so the fairly well-off areas of the world. But if someone's talking about some of these drugs are horrifically expensive, I'm well aware that if cost is an issue, then
wins. Yep.
It does. So it's highly efficacious, but much less expensive.
Correct. Rituxan is administered through the vein, IV, just like we administer ocrelizumab. So it's given every 6 months in the vein. The World Health Organization recently included rituximab and two other drugs as drugs that should be available to anyone with MS worldwide. And I have treated patients in Indonesia, in other areas of the world like India, where there's not ubiquitous access to medicines, but we were able to get a hold of Rituxan in those locations, which I think is fantastic.
And the next one, a little bit different, I think, is Siponimod or Mayzent.
Yes. So Mayzent, Siponimod, is again a second generation S1P1 receptor. So it's in the family of galenia and Ozanammod that we spoke about earlier. Again, I think when we studied Siponimod, Mayzent, we were smarter going into design the trials. And so we actually studied Mayzent in relapsing forms of MS to include people with secondary progressive MS. And here in the United States, it had that added in its label. When I look at the totality of the evidence, again, I view them as more similar than dissimilar. That is to say, the advantages and disadvantages of Siponimod remind me of Ozanammod. I think they're kind of like Pepsi and Coke. And you also have avoided that first dose monitoring effect, which is lovely. And so again, patients don't have to sit and be monitored for the 6 hours like with galenia. I'll make the same comments with Mayzent that I made with Ozanammod, which is I think that the disability progression data leaves a little bit to be desired. Now, when I say that, what I mean is it doesn't look like it's bringing more to the table than the injectables as far as slowing disability progression.
But if you're secondary progressive, is that the only treatment that's approved?
The American, so that really gets into like nomenclature, and I'll speak from the American perspective. The American FDA, when the S1P1 second generation came out, they took an interesting approach and they started to make class effect comments. And so if you look at the labeling, it says relapsing forms of MS. It kind of changed the labeling a little bit. So there's some groups of MS neurologists that preferentially pick Mayzent for secondary progressive MS. I'm not as impressed with that data. And I think that relapsing forms of MS are relapsing forms of MS, and they create a spectrum. And so there are some doctors that might reach for Mayzent in the case of someone who has SPMS, although I don't think that's the only option on the table. I just think that has a lot to do with clever labeling.
And the next is a group here, really, Avonex, betaferon, refib, Xtavia, is another term as well.
And Plag. So these are among the very first class of medicines to come out to treat MS, and they're interferon beta products. So interferons are part of the innate immune response, actually, like that we make in our own bodies. When you have, for example, you catch the flu, your immune system revs up to fight the flu. And one of the things that your immune system does is it makes a bunch of interferons. And the interferons fight off the flu. Now, of interest, the interferon that your body makes is what makes you feel flu-like. It's not the bug that makes you feel headachy and have a fever and joint aches and stuff. It's this interferon. So as you can imagine, if you bottle interferon and inject it back into your body, it can make you feel flu-like. And it's an unfortunate side effect of this entire class of medicine. All the medicines that we just listed off, Avonex, Plag, Rebif, Xtavia, Betaseron, are all self-injections. All of them are subcutaneous with the exception of Avonex, which is an intramuscular needle. And they're given at different frequencies, whether that be every other day or twice a month. There's a whole range. But the medicines are more similar than dissimilar. And what we believe the interferons do in the setting of MS is they tighten the blood-brain barrier, not as good as tysabri, but they still tighten the blood-brain barrier. So they disallow some of the white blood cells from getting into the brain. And that has been shown to decrease attacks, new spots, and slow disability, but only mildly so. So as compared to placebo, these medicines can decrease attacks by 30%. As compared to placebo, they can slow disability progression by about 30%. So when the medicines first came out in the 90s, they were transformative. They were the very first medicines on the market, and they were a godsend. Going from nothing to something is a very big deal. However, 20 years later, as we reflect back, or 30 years later, they're now considered low efficacy medicines, all things considered, because of the ones that have come subsequent to them. Mm-hmm. The interferon medicines, in addition for making you feel flu-like, they're metabolized by the liver, and so we have to check liver enzymes, and sometimes they can mess with the thyroid, and so we check thyroid. Rarely they can worsen depression and worsen spasticity. Bluntly, I try to avoid them in my practice because, again, I start leading with my efficacy as my first tenet. And so I personally tend to shy away from them because I'm reaching for more efficacious medicines.
And another one of the older ones, glatiramer acetate or Copaxone.
This was a medicine that I grew up using quite a bit. My mentor was intimately involved in some of the development of Copaxone. And Copaxone is a first-line therapy. It's an injection, which originally was once daily. And now it's given less frequently. It's given about 3 times a week. And its efficacy data is really almost identical to the interferons. So we now consider it a mildly efficacious medicine, decreasing attack rate and disability by 30% compared to placebo. I would submit to you that it has a nicer side effect profile. And Copaxone still has a role in some situations because glutaric acetate doesn't cross a cell membrane, and it doesn't stimulate a receptor, and it doesn't interfere with any other medicines. It's interesting in the way that it works. It's 4 amino acids, which are in a random proprietary proportion and order, which mimics myelin. So at the molecular level, when you inject Copaxone, you're kind of showing your immune system its target, saying, hey, look at this. And then you keep doing it. Every other day, you're like, look. And your immune system eventually kind of gets bored because it's been seeing that all the time. So when your immune system sees real myelin, it says, I saw that yesterday. And it leads to a shift in the immune response away from a pro-inflammatory to a more relaxed state. That's the way we think that it works. The side effect profile of Copaxone is amongst the least that we would see. And I reach for Copaxone when I'm dealing with, say, MS and HIV, MS and really complex cancer. I used to use Copaxone in pregnant women with MS because it's safe in the setting of pregnancy. You can have it's called an idiopathic injection reaction, which is a doctor term for you give yourself the shot and then you have a terrible reaction where you feel like you're having a panic attack. It's exceedingly rare and it's not remotely dangerous, but I always warn patients about it because if you didn't know that, it would scare you. And oftentimes if it happens once, it never, ever happens again.
And on to the other drug that I had to start off with, which is dimethyl fumarate or Tecfidera.
So dimethyl fumarate, Tecfidera, is a fumaric ester. It's a salt. It's a pill that's taken twice a day. I place Tecfidera, dimethyl fumarate, in the mid-tier category. So when I'm thinking of efficacy, I think it belongs on the same shelf as galenia in those medicines. I think it's a moderately efficacious drug. I think that it does a moderately good job of decreasing attack rate and disability progression in MRI. I don't think it's nearly as good as the high efficacy monoclonal antibodies, but I do think that it's a significant step up from the shots. Tecfidera can cause some unique side effects. One of them is facial flushing, where someone will take the pill and 20 minutes later their face is beet red. Now, it's not dangerous, it's just kind of uncomfortable or a little unpleasant. And oftentimes people acclimate to that, or there's some tricks that you can do to kind of mitigate that, but that's a consideration. Also, Tecfidera can sometimes upset the stomach and cause some GI upset or diarrhea. Generally, that's not too severe. And lastly, Tecfidera is processed by your liver, and so we have to check liver enzymes. Now, the way Tecfidera works is by tricking the cells into thinking that they're under oxidative stress, which causes the cells to create like this antioxidant cascade of lovely, which slows down the inflammatory milieu. Rarely, and we believe this is a side effect, the Tecfidera treated patient will have a drop in their white count. And we don't consider that to be the primary goal of the medicine. It's a side effect. And the reason this is relevant is there's been very rare cases of that PML infection in Tecfidera treated patients if their counts went down, which is very rare. So one of the things that we do as a safety maneuver when we put someone on Tec is we check their white blood cell count and their lymphocyte count for the first several months, 6 to 12 months, to make sure that it's not dropping.
Yeah, so I was taken off that because my white blood cell count went down.
Yep.
And then I was given alemtuzumab, which deliberately got rid of my white blood cell count, ironically. Yeah. So,
but in a controlled fashion.
Yes, intentionally. And then diroximel fumarate or Vumerity.
So there's a second drug in the class with Tecfidera called Vumerity. And we have to be nerdy for a second. So the real name of Tecfidera is dimethyl fumarate. And the real name for Vumerity is diroximel fumarate. When you take either medicine and put the pill in your mouth and it hits your stomach, the first metabolite of both medicines is a compound called monomethylfumarate. So really, both Tecfidera and Vumerity are prodrugs leading to monomethylfumarate. So once you get the drug in you, it's going to do the exact same things that Tecfidera does. Vumerity is actually 2 pills twice a day, which is a little bit annoying for some patients, but it has slightly better GI side effects. And so some patients that had GI difficulties tolerating the Tecfidera were able to tolerate Vumerity a bit better. And again, from an efficacy standpoint, I think that you could almost do a copy paste as far as the efficacy of Vumerity. I would put it right next to Tecfidera.
And next up, Plegridy.
So Plegridy, I would lump in with all the beta interferons. So when we were talking about beta interferons a little bit ago, Plegridy is the newest beta interferon to join the market. It's only a few years old. And what they did essentially is they took a molecule, kind of like an Avonex molecule, a beta interferon, and they added a chemical compound which keeps it around longer. And the result is really nice. So instead of having to inject yourself frequently, a couple times a week, you can only inject yourself twice a month. So you're injecting every 2 weeks, and it's a small needle. Now, I'm not impressed with the Plegridy data as far as efficacy is concerned. I do believe that it's a lower efficacy medicine, but the fact that you don't have to jab yourself so often is very lovely. And otherwise, I would submit all the same comments when we were talking about the beta interferons earlier.
And just a couple left. So Siponimod or Ponvory.
Ponvory is a second generation S1P1 receptor. So it sits next to Ozanammod and Siponimod, right? So it's a galenia Me Too drug. And Ponvory was the last of the S1P1 receptors to join the armamentarium. And it sort of entered into the market in a very crowded space. But all things considered, I think it's very, very similar to the other second generation S1Ps in that you don't have to do a first dose monitoring. There's a titration and the same risk profile and largely the same efficacy as far as doing a really good job with relapses and a less good job, in my opinion, with disability progression.
And I think the last one, so it's quite a big one that we haven't done so far, is teriflunomide or Aubagio.
Yes, Aubagio, teriflunomide. So teriflunomide is a small molecule. It's a small pill that you take, and it's taken once a day. And it's very interesting in the way that it works. It doesn't kill cells, but it makes them kind of play the freeze game, so they can't rapidly reproduce. See, under normal circumstances, your white blood cell can either slowly make copies of itself, that's called the salvage pathway, just to keep it around, or if there's an insult to the body and you need to quickly mount a bunch of clones, then it can make a bunch of cells really fast. And what Aubagio does is it prevents you from making cells too quickly. And so it doesn't suppress the immune system like some of the other medicines, but this shift slows down the disease process. Now, Aubagio is a very interesting molecule. If you look at it from the perspective of relapse rate or from the perspective of new MRI lesions, it's a low efficacy medicine. I would place it kind of in the bottom tier, almost next to the shots. However, if you look at brain volume in disability progression on exam, it does really, really impressive results. And so I, at least in my practice, have found a home for this drug, not up front, early in someone's chronologic age where they're at higher risk of lots of attacks and lots of new MRI lesions. I tend to use this drug towards the second half of the disease, if you'll excuse that expression, when the concern on the table is much more about maintaining brain volume and slowing disability progression, because I think it really shines there. Now, Aubagio is processed by the liver, and it can cause liver enzymes to go up, and so you have to be very fastidious about checking liver enzymes monthly for the first 6 months, because it's most likely going to go up during that time. We also want to make sure that you don't have latent infections like tuberculosis and things like that before we start it. And also, it can cause some GI upset. I would say maybe even more than Tecfidera in my personal experience. Oftentimes that's self-resolving. I have had a handful of patients where they had persistent diarrhea and they had to stop. It very rarely can elevate blood pressure or cause a neuropathy. And an interesting side effect, in about 13 to 18% of patients, it causes a transient hair thinning. Now, we're not talking about like your and my hair. We're talking about that it gets thinner, the density, and more comes out in the cone. When this occurs, it occurs at month 2 and it goes away by month 4. So stopping the medicine doesn't really matter because it's not going to persist for a long period of time. So that's Aubagio in a nutshell.
And is there anything we've missed? Are there any DMTs that we haven't talked about?
Let me run through the Rolodex in my head. We've hit what I call the first line medicines, the injections. And so those are the interferon products, the beta interferon products and Copaxone. We then talked about the second tier medicines, and I would place several pills in this class. Aubagio, with all the caveats that I just gave, the S1P1 receptors, so Ozanammod, Siponimod, the Ponor medicine that you mentioned, and the first generation galenia. I would put Tecfidera and Vumerity in that second tier. I would place Mavenclad at the top of that list. I sometimes call it the king of the pills. Then we get into the proper high efficacy monoclonal antibodies. That would be the tysabri, all of the B cell depleters. So off-label rituximab, as well as ocrelizumab, ofatumumab. And we did forget one, ublituximab. So ublituximab, and again, I didn't make up these words. The trade name is Briumvi. And ublituximab Briumvi is the most recent B cell depleter to join the armamentarium. It's an infusion in the vein as well. The first infusion is given over a 4-hour period. Then subsequent infusions are only 1 hour. It's a B cell depleter, so it goes in the same family as ocrelizumab and ofatumumab, and it works in a very, very similar fashion with largely the same efficacy data. In my personal experience, I've had a little bit of difficulties in patients tolerating the initial infusions, but oftentimes we can get them through that. And so I'm glad that we went through this exercise. I didn't want to forget that one. Then just to round out the list, we talked about natalizumab, tysabri, and alemtuzumab, Lemtrada in that top tier.
And you mentioned these are the DMTs, but you mentioned about symptom management drugs as well. So if people have got, let's say, bladder issues, what would you suggest for that?
So if I take one step back, if we give you a disease-modifying therapy and we prevent new attacks, we prevent new spots from the MRI, and we slow down disability, but you're miserable because of side effects symptoms that are not being treated, we're not doing the best job we could be doing. I believe as an MS treater, we have to do two things simultaneously. We have to slow the disease down using one of the disease-modifying therapies that we just talked about. And then in addition, we need to improve quality of life by treating symptoms that stink. And so if you have bladder urgency, there are some exercises we can teach you. There's timing voids that we can teach you. Ultimately, sometimes people need to take a pill to relax the size of their bladder so they can casually finish watching the TV, then go pee at the commercial. I have a pill for every ill. It doesn't mean I want to give you one or you want to take one, but if something is impacting the quality of your life, I want the person listening to this to be a self-advocate and be a little selfish and say, hey, doc, I really don't like the fact that it feels like my hand's burning. Do you got anything that I can take to make it not hurt so much?
And so is there treatments for mobility or heat intolerance or other common?
Yes. So one of the weirdest symptomatic medicines used to treat MS is a drug called Ampira, or in Europe it's Fampira. The scientific name is 4-aminopyridine. And this is a pill taken twice a day. In my experience, only about 1/3 of patients respond to it. And we're not smart enough to know ahead of time who's going to respond and who doesn't. When someone responds, it buttresses against heat sensitivity and motor fatigue. So one of the insidiously nasty things that can occur in MS is when your body gets overheated, your nervous system can short circuit and you can have the reemergence of old bad things happen, like loss of vision or a weak leg, God forbid, or something like this. When you respond to Ampira and you get overheated, those bad things don't happen. It protects you against that. Ampere is not for everyone. It lowers the seizure threshold. So someone with a known seizure disorder, it's a no-no. It's metabolized by the kidneys, so we have to look into the kidney function and whatnot. But when people respond, it's a near Lazarus effect, like, wow. And sometimes they're very mad at me that I didn't give it to them last summer.
And this is something that I've discussed with my neurologist. You say it's a bit of a strange one because it either works for you or doesn't work for you. In the UK, at least, it's expensive in that it's not covered by our National Health Service. You have to pay additionally for it, and it is quite expensive. But they do actually give you effectively a test month, so that you know. And that's sort of free from the drug company. So you know if it doesn't work, you haven't paid anything, and if it does work, you have to pay.
They do something similar in the United States. It's just like you shared. In the US, it's also very, very expensive. And it's become increasingly challenging to navigate through insurance to get a hold of it. I'll remind people that before the drug manufacturer developed the medicine, we used to have it compounded at old school pharmacies like Mortar and Pestle, where they would make the pills. And you still today can have 4-aminopyridine compounded at some pharmacies. They can't do the exact same strength, but they can get darn close. And I'm just going to plug in my computer. I didn't realize that it had come unplugged. And so there are some patients here in the United States where they're not eligible to receive the drug through their insurance, and we can kind of navigate that by having a similar medicine compounded.
And just a couple of others that are sort of used, maybe a little bit off-label if you like, but low-dose naltrexone or LDN. Have any of your patients had success with that?
So low-dose naltrexone is a very interesting molecule. First, naltrexone is a molecule to combat narcotic overdose. It blocks mu receptors, which interfere with the way narcotics work. And so when we talk about low-dose naltrexone, it's such a low dose that it really doesn't have that effect. And there is a small amount of literature that suggests that it may have some neuro benefit. Now, there isn't class 1 evidence for it. And I will simply say that there are some MS neurologists that believe vehemently that it really, really helps. I also anecdotally have had some patients that ask for it and report back that it helps them in certain ways. It hasn't been robustly studied like the disease-modifying therapies. The way that I think about it, there's 3 things that have to be okay for me to recommend something that hasn't been proven. It needs to not be too expensive, and low-dose naltrexone generally isn't. It needs to not be dangerous, and low-dose naltrexone is not dangerous. And it needs to not be instead of something that I know works. So if someone came to me and said, hey, Aaron, I want to take LDN, in addition to the stuff that we're using, I would say, okay. I would caution, however, about using that as my exclusive treatment for MS, because I don't think the data is adequate enough to guarantee that we're going to win doing that. Again, just my opinion. And
getting on to some of the things that are being studied now potentially for working, one of them is metformins, which are where there's a diabetes drug that's being cross-purpose for MS.
Metformin it's fascinating. This has been a very successful oral agent to help with type 2 diabetes. And metabolically, it kind of recreates a fasting state in the body. And there's some early evidence that might have some neuroprotective benefits. Now, please take what I'm saying with a grain of salt. This has not been proven, although there is a mounting literature body of evidence that there may be some value there. Now, I will share with you that off-label, some patients of mine have opted to go on metformin, and in addition to their other disease-modifying therapies. It's very hard with an N of 1 to be able to see if it's helping someone, but the science is really exciting, and that's definitely one to kind of pay attention to over the next couple of years.
And it's the same effect as fasting. And I know you've had a fasting.
I'm a big fan of intermittent fasting. And I think that there's some things that intermittent fasting can do for the immune system. And so if you could recapitulate that with a pill that you take once or twice a day, that's pretty slick.
And what about things that are on the horizon? So is there any other new pharmaceuticals on the horizon that we should be looking out for?
There's two that I'll highlight that I'm particularly excited about. There's a class of medicines which has been around for a long time to treat cancer and is now being studied very aggressively in the setting of MS. And these are the Bruton tyrosine kinase inhibitors, or the BTK inhibitors. Now, these BTK inhibitors are pills that you either take once or twice a day. And they mechanistically bring some things to the table that are very exciting. So one of the things that these molecules do is they block B cell signaling without depleting B cells. So earlier we talked about several medicines that deplete B cells, which is a very effective way of treating MS, but it increases risk of infection. Well, if a BTK inhibitor can block B cells but doesn't cause depletion, that's fantastic because we might have a similar effect without increasing the risk of infection. Secondly, we know that the MS disease involves both the adaptive immune system, the B and T cells, and the innate immune system, including these cells called microglia, which are in the brain. All the medicines we've talked about so far can't turn off the microglia. BTK inhibitors can. They cross into the blood-brain barrier and they turn off these activated immune cells, which is very exciting. As we make this recording, there are no less than 5 manufacturers all studying BTK inhibitors at various stages, mostly in phase 3 testing. We don't have full readouts on any of them yet. At the Boster Center for MS, we've enrolled many patients into these trials. We're very, very excited about them because we're studying BTK inhibitors in relapsing MS, in secondary progressive MS, and in primary progressive MS. So stay tuned as that data set evolves and as we start to get readouts of these medicines. We're very hopeful. Now, all drugs have side effects, and that's why we do clinical trials. And so far in the clinical trials with BTK, we've learned that they're pretty rough on the liver. And there's been some very serious concerns by regulatory bodies about elevations in liver enzymes. And there's been patients in the trials that we've had to stop because their liver enzymes went up too high. So more to come in the very near future.
But it is near. We had someone from Cambridge University on the podcast, and he was, some of the things we were talking 10, 15, 20 years time. That, unless you're a mouse.
Yeah, that's exactly right. So, I think
but you're talking like 1 to 5 years, are you, BTK inhibitors?
So the very first BTK inhibitor that finished its trial is called evobrutinib. Now, the top line data for evobrutinib left a lot of people sad and blue because it didn't hit. We don't have the full data reported, and all of the other trials are wrapping up. So I think we're going to get readouts on those other trials in the next couple years. So this is not something you're going to have to wait 10 years for. We're looking more like 3 to 5 years is what I would guess.
Okay. And is there anything we've missed?
I'll point out one more class of drug, which is coming after the BTK inhibitors. And going back to the B cell, T cell signaling, you could kill a B cell like the drugs that we talked about today, or you could block signaling with a BTK inhibitor, or you could interrupt the signaling by breaking the connection between the B and T cell. And there's a medicine which is being developed. It's not a new class of medicine. It's new in MS, called the anti-CD40 ligand, right? So that's like a mouthful. And these anti-CD40 ligands are monoclonal antibodies that are just now starting to be tested in MS. At the Boster Center, we're enrolling a trial for relapsing MS and in secondary progressive MS. And what they do is they make it so the B cell doesn't have like the little arm it needs to touch the T cell. So again, coming up with a way of interrupting signaling. And this should have a very robust effect in MS, again, with a lower risk of infection. Now, that's very, very early, so much more to come over the next several years.
Okay, and with that, I'm well aware I've taken up a lot of your time. So we'll wrap up there, but thank you very much. I think it's one to rewind and play back for people who are interested in their DMTs.
I'm grateful for the chance to talk with you. It's always a really good interaction, and I appreciate the opportunity. It's my goal to help families impacted by MS live their very best lives despite having this condition. And I think it's a fool of a doctor who thinks that you only take care of the disease by picking one of these DMTs and taking it. I do, however, feel that DMT is one of the components to a successful treatment plan. And I, again, will leave today with my comment that I want you on the most effective drug that you're comfortable taking.
Okay, with that, thank you very much for joining us, and check out the show notes, and do check out Dr. Boster's YouTube channel.
Thank you so much. Have a great day. Thank you.
Thank you.
Thank you for listening to this episode of Living Well with MS. Please check out this episode's show notes at overcomingms.org/podcast. You'll find useful links and bonus information there. Don't forget to subscribe to the podcast so you never miss an episode, and please rate and review the show to help others find us. This show is made possible by the Overcoming MS community. Our theme music is by Claire and Nab Dean. Our host is Jeff Alex. Our videos are edited by Lorna Greenwood, and I'm the producer, Regina Beach. Have questions or ideas to share? Email us at podcast@overcomingms.org. We'd love to hear from you. The Living Well with MS podcast is for private, non-commercial use and exists to educate and inspire our community of listeners. We do not offer medical advice. For medical advice, please contact your doctor or other licensed healthcare professional.